Well, we are back again with HR the Leader podcast. And definitely after the last episode, I had to bring her back because she literally tried to get my show canceled on the second episode. But guess what? I like her a lot because she speaks the truth and Carri and I go way back. So welcome back, Carri, to the HR the Leader podcast.
Thank you. Thank you very much. I'm very happy to be here.
Well, we're gonna try this again, but please don't get me canceled, please.
I will
All
try
right.
very hard not to get you canceled.
Thank you very
I'll try
much. So
very hard.
all right, let's go back into it. Just in case somebody did not see the previous episode, tell us a little bit about Carri.
So I have been in respiratory since 2013. In 2016, I went back and got my bachelor's degree in respiratory care. And then in 2023, I enrolled at the University of Georgia Terry College of Business and got my MBA. So I've just completed that this past fall. Um, and I'm currently in a supervisory role within an organization in the metro Atlanta area.
Good. All right. So that's very surface. So let's dig a little bit
Yeah.
into it. So for
Okay.
those who don't know, Carri and I worked for the same organization for a little bit, but right after I got hired, she had to leave. But we kept in contact and we seen each other grow in the field. So a little bit about yourself clinically. What are some of your backgrounds? Where have you worked on in adult, pediatrics? Give us a little bit of the clinical side. Then we're gonna talk about how do you transition to the leadership side.
So I started out just as a bedside therapist, doing, adult critical care. When I came to the organization that you and I were both at the time, I had worked in the emergency room quite a bit. And a colleague said, you know what, you've kind of mastered the emergency room. You've really kind of gotten a good handle on it. I really think you need to train in the neonatal world.
Hmm.
And I always joked that after I got my respiratory license that it would come back with like a little, note, do not work pediatrics or something like it just terrified me. In clinical, I was like, if you'll just sign these competencies, I promise I will never come back here again. But you know what? I'm so glad that I did it because I absolutely fell in love with it. It was so rewarding. I had gotten a little jaded working in the emergency room so much and in the adult critical care and even the acute care arena. And just, it's so rewarding to be in the neonatal intensive care unit and L&D. You really get to be there for the best moment of somebody's life. And it's just such a wonderful thing. So that's where, my clinical experience is. I had some clinical experience with peds, but not a ton. I have to admit, it wasn't my absolute favorite. It definitely takes a special person to work with pediatric patients. That is such a special population of patient. So, um, it's not my favorite, but I have some experience with it.
Good. So for the little time that we spent working together and for knowing you
Hmm.
personally, you are a very vocal person.
Yes.
What comes out, and we had to work on filtering, but if Carri thinks it, Carrie's gonna say it. If she doesn't say it, her face is gonna let you know what she's thinking. And I like how we both have grown from speaking our mind. So how did you transition from being a passionate clinician, because I know you're passionate,
Mhm.
how
Yeah.
did that transition to leadership? And are you carrying the same passion? What was the transition like? Because we both talk about I was in leadership before you. I was like, Carri, it's
Hmm.
time to get in. It's time to get in. Nah, nah, nah. There's so much to do at bedside. Carri, you have it. It's time to go in. And
Yeah.
so how was that transition for you? What differently pushed you? It wasn't me. We spoke about it for several years
Hmm.
until you text me say, hey friend, I'm going for it. So what
Yeah.
exactly pushed you to make the leap to leadership?
Well, I mean, mentorship does have a big part to play. I
Mhm.
do have good mentors. I have you. I have my current manager now is a huge mentor for me. So that is enormous for me. But honestly, I do kind of have a mouth about things sometimes, and you can't continue to complain about things without offering a solution and being willing to own some of those problems. And so I just felt like, it's time for me to do that. And I moved from the patient care area um to really wanting to help the people that help the people, or at least try to help the people that help the people. I felt like there was a need, and that could be very impactful depending on, how it's done. But, I had to realize you can't die on every hill. And, you really, it's how you say things. It's not what you say, it's how you say them. So I've had to learn a lot to kind of, simmer down a little bit, and be a little more constructive in how I voice my opinion.
Yeah, thank you for learning that. We can't down
Yeah, you're
every hill
welcome.
because we're not gonna be we can't sustain that. When I tell people
No,
that I
we can't.
cannot win every fight and I cannot go
No,
into every negotiation hoping that is I'm gonna win or hoping that it will go my way. It's not sustainable.
no, it isn't. It isn't.
So are you is did you bring the same passion from bedside, from clinical to leadership, or you had to dial it down, or you had to repackage the passion on how to become more effective as a leader?
So I think getting a business degree helped with this a little bit, because honestly, you know, in the hospital, and this, finance and business are the language of power and money. I hate to put it that way, but it's the truth. If
Mhm.
you want something, you need to be able to make a financial argument to justify it. And so it wasn't until I got in the role that I'm currently in, that kind of sits at the intersection of clinical care and administrative directives, that I really started to see, I'm going to have to be very strategic about how I voice my opinions, the things that I voice my opinions on. And sometimes you have to be willing to sit quiet and just let things play out, and being able to discern when that's necessary, it's hard, but it's an important thing to do. And I think you just instinctually know, I'm not going to win this argument, or I
Mm.
may have a shot here. It's hard, but that's kind of how that happened for me.
All right. So we're gonna go back to the last episode, and there's some stuff that we talk about. I had to bring you back to clarify so us to have a conversation.
Uh-huh.
I think within the first 5 minutes of the last show, you dropped this. We like to eat our own, eating our
Yes.
own, or eating
Yes.
our young.
Yes.
Let's. I had to bring you back just for that. So please elaborate on we healthcare leaders, we leaders of departments, we the
Hmm.
older generation, the experience, the
Hmm.
season. We tend to eat our young or eat our own.
We
Let's
do.
talk about that.
Yes.
How do you feel, and what is that concept for you look like?
So for me, I see it a lot now, and I remember even experiencing it at the bedside. We have a tendency to be very hard on our students and our new grads. And I think everybody has a tendency to forget that they were not born with their degree. Everybody was in the same place at one time. And, I think that a lot of that is just responding to our current circumstances. I think that preceptorship is something that we have not set our people up for, um, not set them up well. I think that we need to do better with preceptorship. And we're not really offering an incentive for our people to get good training or give good training. for that
Mhm.
matter. Um, and I say that because, I have to ask, or I ask myself at times, what would preceptorship, like true preceptorship, look like in a model where somebody was paid to develop a high performer? Because think about what we put on our high performers.
Mhm.
Typically they get the harder assignments. Typically those are the people that we task with training others.
Mhm.
Um, so yeah, that's a lot on them. And then, depending on what organization you're in, you may or may not receive compensation for precepting somebody. So that's a lot to put on someone and then expect them to be nice, you
Sure.
know? And so it's really sort of an unfair situation for both preceptors and students and new grads because you know, these people are being asked to take on more. So, what would it look like if there was a compensation model where they were compensated for how that person turned out? Not not just what they're competent in, but how they actually turned out. If it was outcome based,
Mhm.
then you're not you're creating loyalty. You're creating better outcomes because you're actually investing in getting them.
Mhm.
So that's kind of what I mean by that.
Well, now we talk about that's the ideal world. So now
Yeah.
let's bring our leadership business mindset.
Yes.
How feasible we think it is in this current generation, this current healthcare climate, for
Mhm.
us to really set aside the funds to really have strong preceptorship program in our hospitals?
Mhm.
Is it feasible? Because we have to meet the numbers. Healthcare is
Mhm.
changing from a more value based instead of procedural based. There's a lot more changes where we still have to give the same amount of care or better, but we
Mhm.
still need to become lean to give the
Mhm.
care. But we also suffering from a pop line because we are eating our young. So
Mhm.
where is the happy medium when it comes to good quality preceptorship programs for our hospitals?
So I think that's a very layered question. That's something that
We don't
it's
have an
it's
answer to.
very hard. Yeah, I mean it's very hard. That's not like a one answer question. But I mean, honestly, I think that just, I don't know, there needs to be, we need to be at the strategy table when it comes to
Mhm,
value based care.
mhm,
Um, because what we do is the whole model of value based care if it's
mhm,
done correctly.
mhm,
So I think that's first of all where it has to start is, our value has to be recognized
mhm,
at at the organizational level.
mhm,
Um, and we're going to have to make the decision to devote time and resources to that training and to
mhm,
those programs. Um, so I think that's also going to be important, if we were to ever, go forward with a care model like that. But I don't know. I also feel like, um, gosh, this is a hard question.
It
It's
is, it
really
is. There's
hard.
no real answer of it for me.
There's
I'm thinking
not a
about
good
it.
answer. I mean,
Yeah.
there's really not, but
No.
because there's several things that are broken. I think how we are valued in organizations is really tough for
Mhm,
us.
mhm,
Um, yeah, that's it. It's really hard, but I think that that's where we have to start. You have to ask yourself, like, where is the work on a shift?
mhm,
This is something that I've really had to dive into lately. How are we utilizing the resources we currently have? Where is the work? Um, because, you can't really plan to precept or teach people if you don't know where and when work occurs.
Mhm.
So, I mean, it's very layered. I don't know. That's really a hard
Yeah.
question.
And I think, yeah, because the same thing for me, and this is, I've been around different organizations, and it always boils down to, education preceptors, and we want them to get out of orientation a little quicker because we need them to be on the floors. We have work
Right.
to do, but then once they get out, we just now doing. Remember when we used to do competencies? You had to literally have a whole week off to actually come to the hospital hands
Yeah.
on and didactic and actually put equipments together and really drill us as to, disease processes and actually
Yeah.
putting the ventilator together and troubleshooting. Now we need to get them out quicker. We need to get them competent faster. And but the continuing education has mellowed down because now our organizations are bigger. When we were at the bedside, we probably had a smaller department where you could actually do,
Mhm.
hands-on competencies. But when you're leading over 100, 150, now it becomes more computer-based training. We have
Yes.
moved from hands-on to computer-based training models of education. And that now that's also a way of the future. But I'm asking, is it also gonna hurt us in the quality of clinicians that we are putting out? But
I think it
also,
already has.
yeah, it did. But another part you talked about the last time, which I also follow you on LinkedIn, and you talk about
Mhm.
that a lot. Uh, Work culture. Also, eating our young clinically is a situation, but I think now we are seeing a shift in culture. Back in our day, we didn't know workplace culture at the bedside. We were just lucky to have a job.
Right.
Now it's different. And some of our leaders are not well equipped or in tune to what it calls to have work culture.
Yeah.
So how important you think culture is right now in the mindset or in the culture or in the theme, the concept of we are eating our young or we are eating our own.
Mhm.
Hope you're enjoying the conversation so far. At HR The Leader, our mission is simple: building leaders, transforming organizations, igniting purpose. If you'd like to explore more leadership insights and resources, visit www.hrtheleader.com. And if this conversation is bringing value to you, take a moment to like the video, leave a comment, and subscribe to the channel. Your support helps this platform continue to grow. Now, let's get back to the conversation.
The biggest thing with culture, and I think that this is where it goes sideways. Almost every organization that we know of has mission, vision, values, things that they say are the culture.
Mm-hmm.
But your culture is your lived reality.
Say it again.
If your culture is your lived reality.
Yeah.
So if you have words on a banner, you can plaster words on a banner on every hallway. But if your lived
Mm-hmm.
reality is not the same, your culture is broken.
Mm.
And that to me is where the biggest problems are because we are not doing what we are saying is important to us.
Mm-hmm.
And you internalize that as a bedside person. And that's where trust breaks. People, especially, when you talk about culture, when you're talking about just culture, psychological safety, all of those things that it takes for people to feel safe in their role, to teach, to learn, to grow. You don't have those things because
Mm-hmm.
people don't have any trust that organizations will do what they say they're going to do by them. It it's very broken. It becomes very broken.
Yeah. Yeah, difficult. And right now, engagement, retention, culture, those are as important as the right diagnostic, the right care model, because everything
Yeah.
now is we having a wholesome approach of healthcare. Back in the day, we were focusing on mostly curing the patient, purely patient care. Now, as leaders, you
Hmm.
need to focus about delivering the best care and also
Yeah.
taking care of our staff.
Yeah.
So in the last episode, that's why I brought you back, because you drop a lot of gem in the last episode. You talked about preventive versus curative medicine.
Hmm.
You saying that we are seeing a shift, that we are
Hmm.
now have to be more on the preventive side, more into
Yeah.
the teaching, more into the prevent readmission than, oh, well, you come in with the COPD, we need to do ARDS and everything else. All those are great, but now respiratory have to do a better job getting into the preventive medicine. Let's talk about preventive versus curative, and how do you see the shift, and where do we respiratory therapists have to adapt?
Well, I think there's a lot more opportunity now, especially
Mm-hmm.
with the advanced practitioner role on the horizon. I know all the states haven't approved that role, but there's tremendous possibility there.
Mm-hmm.
There's also, I think, more opportunity for therapists to work outside of the acute care environment. I know that that has been a real issue for getting people into our field. Is a lot of times people will choose nursing just simply because they feel like there's more opportunity outside of the hospital to do
Mm-hmm.
that. I think that that is shifting a little bit, but our value is in assessment and education. I know, like, critical care, everybody loves critical care. I love critical care. It's one of my most
Yeah.
favorite things in the whole world.
Yeah.
But really the value is outside that. If you look at it or you think about it, by the time somebody gets to the ICU, it's too late.
Mm-hmm.
Prevention is out the window.
Mm-hmm.
So, once you get them out of the ICU, if you can get them out of the ICU, then you got to focus on preventing them from going back to the ICU.
Mm-hmm.
So, we really have to step it up in the acute care space.
Yeah.
So that to me is the difference. And, what makes it hard is as well as I do, that very few things that we do are reimbursed. And so that makes it so hard for us to get resources to be able to do what we need to do, because, you know, it, if you don't generate revenue, you're easily overlooked. So that's why
Mm-hmm.
we have to be very, very strategic as a discipline about the patients we see.
Yep.
Right patient, right time, right treatment, all those
Mm-hmm.
things have to line up, and we have to
Mm-hmm.
be very intentional about who we see and what we do to make an
Going
impact.
So that makes great sense. So you make this conversation so easy. That goes straight to the next question that we talked about, that you talked about as well on the last
Hmm.
podcast, value-based medicine.
Hmm.
So we both could sit and say, we see the work, we having staffing issues, we see that the
Hmm.
staff works hard,
Yeah.
but it doesn't show up a lot on the productivity sheet.
Yeah.
Or when we're looking at, the revenues, or we're looking at productivity from a finance standpoint, it's either we are making it or we are barely making it, but we are not way above, and our margins for respiratory therapists are very small. But
Right.
we are out here really doing the work. We are dealing with staffing challenges.
Hmm.
So how do we transition from a productivity base or a procedural base onto a treatment count, into your CAC counts, your points for the day, into a value based approach that also goes to preventive medicine? So I still think, as a healthcare system, respiratory as a field, we have not crossed over to that mindset. And what is holding us back from that?
So, in my opinion, what I think the issue is, I have lived and died by clinical activity time, by cat counts. That is the AARC
Yep.
recommended way
Yep.
of establishing your productivity
Yep.
metrics. The problem is that you can't apply cat counts to readiness based areas. There are areas, the ER, labor and delivery, some hospitals, staff for rapid response. Those are readiness based areas. And you cannot apply clinical activity time, in my opinion, to readiness based areas because when
Mhm.
you start trying to flex from readiness based areas, you are always going to be short.
Mhm.
So, clinical activity time has to be applied to volume based areas in order to be able to reliably flex staffing.
This is
So,
good. This is
it's
good.
it's got to be a clean metric. And I think the
Mhm.
problem that finance sees is it's not a clean metric because it
Mhm.
ends up looking like excess capacity when you have people sitting in these areas, but you still have to count them.
Yeah. Yeah.
So, for us, I think that that is a battle that we need to fight, and we need to that might be a hill to die on right there
Yeah, no,
because
yeah, it's important for sure.
it's super important. And so I think that, that would be a good starting place for us. I don't I don't know.
Yeah,
That's
and I think one of my good friend mentor, he said, it's either we are at the table or we are
yes,
on the menu. So we need to start
exactly.
being at the table to start making those shifts, to start talking that language, uh, because because we always had that comparison nursing versus RTs. But when you're
Right.
looking at nursing, they have 1 to 2 ratios. We have an
Mhm.
entire hospital.
Yeah.
They are unit based. They are hired by their unit as a smaller group. We are leading an entire hospital. We have
Yes.
a mixture of value based spaces, and we also have a portion where we have volume and cat count. So we actually
Yep.
have a mixture of it all on a 12-hour shift
Yeah.
compared to a counterpart. So radiology is purely procedural based, but
Yeah.
we respiratory, we have a portion of everything in a 12-hour shift,
Mhm.
flexible, fixed hours, variables, everybody we need to manage to make it work. So we
Yeah.
need to start being invited and create a space at these tables for us to be heard. Good point. Good point. I like that.
Well, I really think like that is where we can really provide enterprise value. I
Mm-hmm.
really believe, when you're talking about a value based care model, uh, we absolutely should be at the strategy table because
Mm-hmm.
everything we do is value, like it is centered around value based care. Like that's the
Mm-hmm.
whole premise of what we should be doing. So, it I really, it almost like just makes me scream inside, when we talk about value based care and then, respiratory therapy is not able to have resources. Cause I'm just like, guys, this is where we can shine right here.
Mm-hmm.
We can really help save organizations a lot of money, but we have to be measuring how effective we are. Do we
Mm-hmm.
have good metrics for that? What does that look like for us? Are we seeing how many times a patient does not end up in the unit? Because for
Mm-hmm.
us, what didn't happen is as important as what did happen. So, how
Mm-hmm.
effective are we being at doing these things?
Mm-hmm. Mm-hmm.
And that's really hard to show. It
Yeah.
it's really challenging to show. So, when you get to, the finance and budgeting conversations, it's really difficult to make that argument.
I like what you just said. It is as important to document what happened and what did not happen. Because if we are missing on the value base on the preventive side, they are ending up in the ICUs. But we also have, the mismanagement of resources. Yeah, this is awesome. This is great.
Yeah.
Yeah, we do have it tough, but I think I'm happy to say that we still evolving into the right direction. It may not be as fast enough. I think we're not catching. I think we are behind the eight ball how fast healthcare is moving, but I am very optimistic that we are, as a field, respiratory is moving with the times, but not as fast. Because where we came from, I could see that the field has evolved a whole lot, and I'm
Oh,
happy
for
to
sure.
see the changes happening in the field.
For sure. Yeah, I mean, I think that for us, the things that we're documenting, the assessments that we do, um, I think that we as a whole need to look at the questions that we're asking patients, the data
Hmm.
that we're collecting from patients. I think, we need to start making sure that our metrics reflect um, what didn't happen,
Hmm.
that could have
Hmm.
happened that didn't happen so that we can show some value there because we're tremendously valuable. I think I said this in our podcast. I can't remember. I know I've written it several times, but I compare us to cybersecurity. You
Hmm.
don't wait until there is a breach to justify having cybersecurity. Same thing for us. You don't wait until there's an ICU admission to justify respiratory. By
Say
then,
that again. You have
too
to say
late.
it again. You have to say it again, Carrie. Woo! This is good. Say it again.
You don't wait until there is a breach to justify cybersecurity. We are the same way. Respiratory therapy, by the time they're in ICU, it's too late.
I
Your
like that. I
costs are
like that.
locked in, your margins, are no longer protected. Now you are at the mercy of whatever happens. So that's why I'm like, finance, please understand. Like, we are margin protection for you. We will help make sure that this hospital is profitable. But we have to do that saying, trust us, and that it doesn't work that way. So,
Mm-hmm.
I've also talked, in some of the writing that I've done about clinical activity time being a leading indicator of a system that is under strain or an acuity that is rising.
Mm-hmm.
I really think that clinical activity time can be viewed that way because, when our clinical activity time starts increasing, it's increasing everywhere else in the hospital.
Mm-hmm.
Because, we're just one part of it. APCs, the, ambulatory payment classification that we get reimbursed with, that's a lagging indicator.
Yeah, it's behind. Yep.
By the
Yep.
time you're doing all these procedures and all these things, it's too late. Like,
Mm-hmm.
you want to catch it. You don't even want this patient to be in the hospital. We got to catch them in
Mm-hmm.
the ER. So, like,
Mm-hmm.
that's why, like, don't make us flex from that area. That allow us to have people there, allow us to prevent people from ever coming into the hospital to begin with, so we don't even get to that place.
Hope you're enjoying the conversation so far. At HR The Leader, our mission is simple: building leaders, transforming organizations, igniting purpose. If you'd like to explore more leadership insights and resources, visit www.hrtheleader.com. And if this conversation is bringing value to you, take a moment to like the video, leave a comment, and subscribe to the channel. Your support helps this platform continue to grow. Now, let's get back to the conversation.
Well, on the last one, there were two other ladies on the panel. We talked about
Mhm.
women in leadership. So this
Uh-huh.
time, I'm still gonna have to talk about, how it feels to be a lady, a
Yep.
woman in leadership. Um,
Yes.
and I wanted to ask you to give me some nuggets that you did not give me the last time. And you and I could have this conversation, and I think you won't feel offended by it. Um, at times, people may feel like, Caucasian women may have it easier
Uh-huh.
being in the corporate area compared to some of my counterparts and women in leadership. So give
Yes.
me your perspective with everything you had to deal with in your area, with what you have to do with,
Mhm.
how it is to be a woman in leadership. How is Carrie navigating leadership as a woman?
So I think as a woman, once again, it's not what you say, it's how you say it. Women are just interpreted differently. And, a man and a woman can have the same struggles, but a man, if a man is struggling, a lot of times it's, an individual, they're going through something. It's an individual challenge. But for women, it turns into a generalization. Oh, well,
Mhm.
she's a woman.
Mhm.
And so that can be very, very frustrating. Um, and I think that, two people can say the same thing, but it just be received so differently depending on the gender of the person that it's coming from. And, I mean, at the risk of sounding like a Taylor Swift song, um, which I don't want to do, but I mean, there's definitely a difference. Men have a tendency to be believed a lot faster when there is an issue than a woman does. If we come in hot about something, or we feel strongly or passionately about something, it's, you know,
Mhm.
she's just a lot. Like she's just passionate. It could really be brushed off
Yeah.
a lot faster. And, that's why I feel like as a woman, it is so important that we support other women. Um, we don't have to agree on everything. We don't have to agree on anything, but we need to support each other and give each other the tools to succeed. And I don't think we do a good job at that always.
You don't have to give me a clear example, but in your journey, have you experienced, uh, anything on that gender bias that you felt was unfair when it came to your journey and how you went through from clinical to now a leader? And I'm pretty sure you've been in different rooms. I've seen you grow. Have you experienced um, not being heard the same way? Or have you experienced anything that makes you say like, wow, it would have been a different outcome or a different conversation if it came from a male counterpart?
Um, in my current role, yeah, I mean, not necessarily as much on in the business side of it, just simply because of the exposure that I have in my current role. I'm not in a ton of situations yet, to really have had an experience like that, but most definitely as a clinician, as a lead person at the bedside, if I came and said that there was an issue with a patient, it would get poo-pooed off a lot more than if a male came and said it.
Wow.
So it definitely you can tell in the subtle things.
Hmm.
I have been very blessed so far to in the exposure that I have had to have been supported.
Hmm.
Um, check ask me this question again in a couple years, I may have a very different answer. I don't know. I feel like it is it's just different. It I know that there are a lot of women who have had not good experiences.
Hmm.
I just I'm fortunate that I haven't encountered a ton, but I'm also still going. So I don't know what I will encounter up the chain, and I just pray that, when that day comes, and I'm sure it will, that I'm able to handle myself professionally
Yeah,
and appropriately.
let's keep working on keeping the
Yeah.
passion. That's because
Yeah.
we've seen each other grow, and I definitely like what I see in both of our lives and how you are evolving as a leader, how I'm doing, and I like those relationships, and I value them a lot from where we started to where we are now. I'm not gonna keep you long, so if you had to encourage a clinician right now and encourage a word of encouragement for a leader, why would it be as we close?
So I would say to a clinician, you don't have to be a leader to lead. If you see something, say it. I mean, just, don't be afraid to say it. Don't be afraid to come up with solutions. And to leaders, don't be afraid to speak up. Don't be afraid to die on the hill. If something is important, advocate for your team. You work for them. You really do. I've said that before, and I'll say it again. I work for my team. I'm their voice between the bedside and administrative leadership, and I take that very seriously, and I would just ask that they take that seriously too. We It's really hard, I know. Whenever you reach a certain point in leadership, you want to get ahead, and you don't want to sell out the people that report to you to do that.
Hmm.
It Pleasing the people above you is important, but making sure that your team you are leading, that they are happy, that is way more of a priority,
Yes, it is. It is.
and it should be.
It is. Well, Carrie, thank you very much for coming back to the
Thank you.
platform. You're a friend of the platform. You and I go way back. And thank you for your time. You definitely drop a lot of gems. I'm pretty sure a lot of people, when they hear this, they're going to learn a whole lot from value based to eating our young, eating our own, to preventive medicine, to cat counts versus APC. You dropped so
Mhm.
much great knowledge on this short period of time on HR Leader podcast, and I wanted to thank you for saying yes. And I'll see you next time.
Absolutely. Thank you so much. I appreciate it.
Bye.
Bye.